Welcome to the first day of 49 Sri Lanka Surgical Congress. It's the annual sessions of the College of Surgeons of Sri Lanka in collaboration with the Royal College of Surgeons of Edinburgh and the SAARC Surgical Care Society. After a successful day of yesterday's pre-paper sessions, today we are going to commence today's program with the SAARC Symposium. The topic is Emerging Trends in Surgical Training and Evaluation, Country Perspectives. So today's sessions, the chairpersons, I would like to introduce the chairpersons. Dr. Narendra Pinto is the past president of the SAARC Surgical Care Society and past president of the College of Surgeons of Sri Lanka. And Dr. Rezni Cassim is a consultant vascular surgeon at National Hospital of Colombo. And we have a special guest today, that is Professor Arjun Alvihare. He needs no introduction, and he was a founder president of the SAARC Surgical Care Society and the past president of the college as well. We are honored to have you, sir. So I would like to hand over the sessions to the chairpersons now.
A very good morning, ladies and gentlemen. I warmly welcome you for the SAARC section of the College of Sri Lanka Surgical Congress 2020. Today is a sunny morning, but we are the whole western province, including Colombo, is clamped down with a quarantine curfew. So we are. So this is the new normal, and we'll try to make the most out of it. I'm delighted to have Professor Arjun Alvihare among us, and he is as already mentioned, he is the founder president of the SAARC Surgical Care Society, and this society is the brainchild of his. And in 1996, he mooted this idea and established this society. Now it's going to be the 24th, and next year it's going to be the 25th anniversary. Good morning, sir. Now let's start the SAARC Symposium, and the first speaker is my friend Professor Sunil Sharma, and he's the director of the Nepal Medicity and consultant in GI and laparoscopic surgery since 1998, and his profile is on the screen. Without wasting time, over to you, Sunil.
And giving me this opportunity to speak during the SAARC Symposium. I represent Nepal, and I'm going to be talking about the surgical training challenges, the Nepalese perspective. Well, next slide. First of all, if you look at the surgical training available in Nepal, we've got a very young system of having a master's degree which has been started in 1994. This is the old tested master's degree that has been borrowed from neighboring India. And although we are a young country to start post-graduation studies in this region, we are still following a very archaic old system that has been copied. Unlike some of our neighbors who have done much better in medical education, we are still lagging behind. I would like to state that we started just in 1994, and there are 3 universities which have affiliation of around 22 government as well as private medical colleges, and that offer seats every year between 80 to 94 seats a year. And this basically belongs to the number of preceptors available for that particular year. Apart from that, there are 3 deemed universities or institutions that are run on their own, and they give around 24 seats. These 3 deemed universities belong to the government, and they actually give most of the seats to government candidates. So the total number of positions available to the Nepali graduate every year is around 104 to 120. However, the free competition is only 70. Apart from that, we have the FCPS under the College of Physicians and Surgeons of Pakistan. Now, this course has been running in Nepal for almost 2 decades, and it's matured into a very good residency program where a lot of young trainees do their FCPS training under various consultants and then they go to Pakistan for their exams. The majority, although training is done in Nepal, the majority of graduates tend to go to neighboring countries to do their post-graduation. And as I have cited here, the majority go to China, Bangladesh, Philippines, Thailand, and India, and of course other foreign countries like the America or United States, United Kingdom, Australia, Singapore, but these numbers are very few. And as I've cited, China has the highest number, followed by Bangladesh, Philippines, and Thailand. India these days, the number is dwindling. Right, let's move on to the next slide. Now, as the demand of the time and the patient population, super speciality is the need, and everybody seems to be stressing mainly on super speciality, though the rural setup is doing a very good, is being serviced by the MS General Surgeon. And in the rural setup, I must say that the Nepali training has provided a lot of good surgical care. But in the urban setup, in the big cities, is the super specialty training, which has almost replaced the MS General Surgery. And again, we've copied the system from India, and we've got MCH in various specialties. Again, a very university-based, and this was started just in 2010. We are very young, and we've started with gastrointestinal, urology, neurosurgery, plastics, thoracics, cardiovascular, and pediatrics. Again, the number of seats in MCH is very limited. For example, in GI surgery, there are just 12 seats throughout the country. So there is a huge bottleneck as regard postgraduate education in Nepal is concerned. So a lot of specialists will go abroad for either fellowship or further training. For example, they will go to Bangladesh for a 5-year super specialty training course, or to the Philippines, or even a PhD in China, and for a fellowship in Singapore, Korea, the United States, United Kingdom, and Australia. So what are the challenges? The biggest challenge is this is a very archaic system. Thesis is done, but it's a thesis with very little implication. There's no standard format. There is no teacher standardization, and logbook is still manual. What do I mean by teacher standardization? Anybody who is a preceptor, no matter how old they are, they will be able to teach that particular student, and the teaching is not standardized. So there is absolutely no assessment of skill and competency. It's purely knowledge-based, and examinations are equally archaic. We still follow the old system of the theory exams followed by practicals. Unfortunately, there's no standardization, so individual variants will be applicable not only to the trainee but also to the trainer. So if you've got a good trainer, the chances that the training will be good. Whereas if you've got a bad trainer, then of course, as they will say, inshallah, God wishes only. So the biggest challenge about this system is that it's a bottleneck system. So although we've got a huge graduate numbers, that is around 3,000 every year, the numbers going to post-graduation is hardly around 700, and whereas going to super specialty is not more than 150. So there is a big challenge. So however, are there any advantages? Of course, there are a few advantages. Number one advantage is that it's very suitable for the periphery of our country. And the second thing is, unlike our neighboring countries, all our graduates, no matter where they've qualified, in their master's or the specialty training, must sit for the specialty licensing exam held by Nepal Medical Council 3 times a year, and they will be able to practice only after they've obtained the license in that particular exam. So that way there is some amount of standardization. So what is the solution that we're working towards? Well, first of all, the government has finally realized the big need of improvement in medical education. So we've been established with a national board, and the national board is working very, very extensively. And within 6 months to a year, we're going to have a national board training system. And first of all, there'll be standards of the trainees. Now, how do we plan to do that? We're going to be giving the responsibilities to professional bodies. For example, the Society of Surgeons of Nepal, or the SIMON, which is the Society of Internal Medicine Group of Nepal. So they will take responsibility of their particular trainers, and they'll also look into competency and skill, and they'll ensure that the curricula and the examination system is modernized. Of course, we'll be stressing on electronic data. There will be compulsory formatted training. For instance, basic surgical life course, and basic surgical course, advanced trauma and life support courses, and in orthopedics, the AO courses. In general surgery, laparoscopy courses, they will be compulsory and they'll be formatted. The last other advantage is there's going to be rotation through both urban and rural setup. So that will mean utilization of rich personnel that are working in various private and semi-government organizations or public institution which was not recognized in the university system. These teachers will be recognized and they will be used as resource persons. The other solutions, as I already said, is involvement of, next slide, is that we'll be using professional bodies like the Society of Surgeons. They will be responsible for the course, the curriculum, the trainers, and the exams. And standardization courses will be run by these professional bodies. And apart from that, they will ensure that accreditation for certain procedures like endoscopy, laparoscopy will be made, and compulsory CPD for trainers will be made. So we hope with this, with looking at the examples of some of our neighbors who have done extremely well, for instance, Pakistan and Sri Lanka, we would like to bring about change in the surgical training of our country. Thank you very much, and thank you for giving me this opportunity.
Thank you, Sunil. Yeah.
Now our next speaker is Professor Bawantha, who is a professor in surgery at the Faculty of Medical Sciences at the University of Vijayawada, and he is the Secretary General of the SAARC Surgical Care Society at this point of time. And over to you, Prof. Bawantha.
Okay. Good morning to all Sri Lankan and overseas participants who joined with College of Surgeons of Sri Lanka in solidarity during this pandemic. I can't imagine a better topic than emerging trends in surgical training and evaluation to start Sri Lankan Surgical Congress 2020. In next few minutes, I will surgical training. In the past, this is how we train our trainees. I'm sure not only in our country, but several other castes. We change our surgical training program, not only focusing on trainers in order to achieve a high quality training program and also to produce a few years. Currently, are given MRCS degree without examination by the Royal College of Surgeons of Glasgow. This tells us factory. In addition, we produce specialists during daytime and generally catering the country's requirement. Concentrating more on the concerning has three aspects: training the trainees to become surgeons, that is developing operative and non-technical skills. Second, training the surgeons to develop new skills. I call it re-skill and upskill programs. Then training the trainers to be good evaluators. The whole body that is responsible for governing, controlling, and quality assurance of the surgical training program in Sri Lanka is Board of Study in Surgery in the Postgraduate Institute of Medicine. Training the trainees to become surgeons. We select our trainees, about 50 to 60 per year, after selection examination, and then they undergo 38 months of extensive hands-on training. During this training period, they are subjected to surgical in-training assessment, and also they have to follow basic surgical skills course, national trauma management course, and laparoscopic skills course in addition to research project. After 38 with MCQ paper, SCQ paper, clinical examination, which consists of OSCE and OSFE. About 30 candidates get through every year through the MD examination. After MD examination, there is 3-year compulsory training, post-MD training, out of which 1 year is compulsory overseas training, for which Government of Sri Lanka provides them paid leave. And during this overseas training, confidential feedbacks are sent to Postgraduate Institute of Medicine by the trainers. After completion of 3 years post-MD training, there will be a portfolio-based viva. Successful candidates will be board certified as specialist surgeons with special interest. Mr. Chairman, there are unique features in Sri Lankan surgical training program. First, it is controlled and governed by a single body, that is Postgraduate Institute of Medicine of the University of Colombo. And there is compulsory overseas training, which is with paid leave by the Government of Sri Lanka. All our trainees, after getting through MRC, the MD surgery examination, are offered MRCS by the Royal College of Surgeons of Glasgow. Not only that, all trainees are given permanent jobs as consultant surgeons by the Government of Sri Lanka, either in the Ministry of Health or in the university system. Second aspect, training the surgeons to develop new skills. Of Sri Lanka, we started regional assisted mentoring program. This is a concept by Dr. K.L. Fernando, then the president of the College of Surgeons of Sri Lanka. Then in 2020, we started Surgery Head program, which is running very smoothly up to now on Zoom platform. We have conducted about 5 successful sessions up to now. The youngest member of the College of Surgeons of Sri Lanka, Sri Lanka Association of Minimal Access and Digital Surgeons, have formulated an extensive training program, which is going to be started from 2021 to develop skills in minimal access surgery in our surgeons. What about training the trainers to become good evaluators? If you want to become a trainer, the Postgraduate Institute of Medicine has made compulsory all the trainers to participate training the trainer course. If you want to become an examiner, they have to participate the examiner training course. Not only that, we have surgical trainee days, which are good eye-opener for all the trainers because they get feedback from the trainees. Then assessing the examiners is compulsory now. Independent assessors appointed by the Postgraduate Institute of Medicine and the Royal College of Surgeons are assessing our examiners during the exam. And also they get feedback from individual feedback. So there's room for improvement. Mr. Chairman, in summary, Sri Lankan surgical training is governed by a single body. Therefore, quality assurance and assessment is quite uniform and easy. Sri Lankan surgical training was changed from subjective to more objective, problem-based, based training program with pertaining skills development in trainees, pre-skilling and upskilling of practicing surgeons, and training the trainers to become good examiners and trainers. All the trainees are assured permanent post by the Government of Sri Lanka after completion of their training. So we have overall quite satisfactory surgical training program in the region, and I'm again thanking you for the College of Surgeons for giving us this opportunity to discuss our training program. Thank you very much.
Thank you, Bawantha.
Our next speaker is Professor Pawanindra from India. He is a director, Professor of Surgery, Maudud Azad Medical College, New Delhi. His special interest in surgical and laparoscopic surgery. He is a member of all the national surgical bodies in India and some of the national bodies in UK and USA. He is the Vice President of the International College of Laparoscopic Surgeons and the Indian Hernia Society. He is a recipient of many prestigious awards and fellowships and scholarships. Over to you, Professor Pawanindra.
Thank you, Chairperson. A very good morning to all the delegates. At the outset, I would like to thank the organizing committee of the Sri Lankan College of Surgeons for this very kind invitation. I bring greetings from my institution, Maulana Azad Medical College, the National Board of Examinations, and the Association of Surgeons of India. During these past year, the association has been carrying out various courses for its trainees, including basic surgical skills, anastomosis skills, basic laparoscopic skills, critical care courses, and also communication skills courses. During the period prior to the COVID-19, physical courses were being organized this year of various types and were being run very successfully until, of course, COVID came, when the leadership of our association, ably led by our president, Dr. Raghuram, interacted with the leaders of the country at various forums for the healthcare policies that were being evolved, and also brought out consensus guidelines about what to do and what to do, not to do during this COVID-19 pandemic. The association continued to build and provide the training through the National Skills Enhancement Program, which was geared towards the practicing surgeons and the trainee surgeons. Also did the case-based discussion programs, which were the regional refresher courses across various regions of the country, mainly geared towards the surgical trainees, and then decided to continue with the annual conference of the association, which is being held in a virtual platform between the 17th and 19th of December. It will be a 3D immersive experience for all of you. And on behalf of the association, I take this opportunity to extend this invitation to all of you and join us all through the website and participate in this mega online event. The current surgical training in the country is carried out under two basic controlling mechanisms. The university programs provide the Masters in General Surgery, and the National Board of Examination provides the diplomate of the National Board in General Surgery. Both of these courses are post-MBBS courses of 3 years duration, and there is a current discussion and deliberation being held as to whether this 3-year course is optimum or should it be increased, because it is less definitely than the 5 years training that currently goes on in the United States, 6 years in the UK, Europe, and Australia. The National Board, during this period of lockdown, used the opportunity to convert the problem into an opportunity and pioneered successful launch of web-based learning program using the web mode with 1 hour classes for all subject specialties in the whole week, and reaching out to almost 5,000 students at one time. This was one of the first of its kind initiative and was very successful and is running in all subjects at this time. It also continued, the National Board continued to deliver the exit exam of the DNB to provide the opportunity for people to exit from their training, and because of the COVID situation, modified this examination into an OSCE based exam and used these objective structured clinical mode, which was launched from the command center at NBA headquarters in Delhi. And very successfully, this exam was rolled out to more than 3,000 students across 27 specialties in the first phase. This included OSCE stations, which were virtual, and physical stations at various centers, which had a virtual case as well as clinical skills demonstration opportunity on mannequins, dummies, and healthy human volunteers. The National Board also has announced this year a very special opportunity for international students in the form of a 2-year fellowship program, which is currently available in 4 surgical disciplines in minimal access surgery, trauma care surgery, hand and microsurgery, and spine surgery. This involves per annum cost to the student of $5,000 to be paid to the institution, but gets a nominal salary equivalent to the Indian candidate in the hospital concerned. And I invite you and extend this invitation to all the Sri Lankan students who are keen to come into this fellowship program and participate in the next announcement of this which is going to happen very soon for the session starting in January and February 2021. The Association of Surgeons of India has also successfully launched the online surgical skills module in the current COVID situation to ensure that the surgical trainees continue to have their surgical skills alive. And here I am demonstrating this on a web-based platform, and this video shows how it is possible to deliver this when this particular trainer is also provided to the students at their own particular places wherever they are located. So to summarize, ladies and gentlemen, there is a current debate about the 3 years versus the 6 years training in general surgery. The COVID period training has to be addressed carefully by making sure that adequate hands-on skills are kept alive in our trainees, and non-skill courses like communication skills continue to be provided. And assessment of trainees may need to be modified in this situation when there is a threat of COVID to the students. So it may be needing to be converted and needs to be deliberated and modified as we have shown. Once again, I would like to thank the organizing committee for this very kind invitation. Thank you very much.
Thank you, Professor Pawanindra.
And our next speaker is no stranger to us, Dr. Sonam Dargay, our friend and our dear friend. And he's the post coordinator and assistant professor for the surgical residency, dear friend. And he's the post coordinator and assistant professor for the surgical residency program in Bhutan. And he has many interests other than this. And he also has spent time with Prof. Alamgir at the University of Perak in the Professor Surgical Unit. And I now welcome Dr. Sonam to deliver his talk.
Good morning to you all. At the outset, I would like to thank the organizers for giving me this opportunity to talk on the topic Emerging Trends in Surgical Training and Country's Perspective. This slide shows the Jigme Dorji Wangchuck National Referral Hospital. This is the place where I work and also train our residents. It's a 381-bedded hospital with 20 departments and 1,303 employees. It's the highest referral center where we get all the complicated cases from other parts of Bhutan. And to go on to the surgical training, initially, it was kind of an apprenticeship whereby the student was attached to the teacher and the student learned as the teacher performed and depended mainly on the teacher and the student relationship as to how much he can learn as a surgeon. But over the years, it's slowly evolving with the internet, the virtual reality, and the development of artificial intelligence and robotics. Now my residents have all the textbooks in their smartphone. They can watch videos online and watch the different surgeries being performed without actually going into an OR. My time we had to dig into books and spend hours trying to gather a simple information and had to scrub in every possible cases to get experience and to see. But there is also some drawbacks with this today's world, because if the residents don't authenticate the source of their knowledge and also the source of the videos, if performed by an expert or not, they could be learning the wrong things. The dictum see one, do one, and teach one is slowly changing to see one, do many on simulations, and then do on patients. Before 2014, we didn't have a residency program, so we all had to go out to do our residency. But in July 2014, we started with 2 residents, and till now, we have produced 4 surgeons who are doing very well. And presently, we have 8 residents, 3 in final year and 2 in each in other years. This picture shows the 2 residents with their scarves around their neck, and the person sitting in the second row from right is our Honorable Prime Minister, His Excellency Dr. Lotus Singh, who was with us then as a sole practicing urologist. And we are honored to have him as our Prime Minister now and fighting the COVID. And in the middle is Dr. Tenzin, who is the Dean and also the President of the Bhutan chapter of SAARC Surgical Society. And with whose blessing, I'm giving you all this talk. When we initially started, we had less number of surgeons, just 4 of us. And therefore, our residents had enough cases to learn. Now, with each passing year and with more surgeons passing out and also coming from other countries, we fear that one day our residents may not be having enough cases to learn. So therefore, we had to find an alternative, a simulation lab. But the simulation lab, are they good enough substitute for the residents? Will they replicate the real OT scenario? Or can they replicate all the cases? I still doubt. And just to illustrate this, I'll show you some cases down in the other slides. This case of acute intestinal obstruction with gangrenous bowel, a blunt trauma to the head, blunt trauma to the abdomen and groin injury by RTA, and arrow injury, which is quite common during festival time since archery is our national game. So will the simulation lab simulate this type of cases? And then this coronavirus now, how long is it going to stay? And if it persists, how are we going to proceed with the training? So many things unanswered, and I hope we'll get an answer very soon. So with this, I end my talk, and I would like to thank you all for this patient hearing. Stay safe, stay healthy, and touch the leg. Thank you all.
Thank you, Sonam, for the good talk, and we are very happy that Bhutan has started training. And our next speaker is Dr. Muhammad Farooq Afzal from Lahore, Pakistan. He is a pioneer in bariatric surgery in Pakistan. And over to you, Professor Afzal, Dr. Afzal.
All right. I've been given a task of speaking about current challenges in surgical training. My name is Professor Farooq Afzal, and I'm president of the Society of Surgeons Lahore chapter. Thank you for the invitation here. All right, so the objective is to highlight the current challenges affecting the postgraduate surgical training and to discuss some of the solutions. As you all know, that the goal of postgraduate surgical training is to produce surgeons who are safe for the society. But the greatest challenge is that there is a direct relationship between patient safety and these residents' autonomy. So if you are training them and the training is too liberal, there are high chances of patients' harm. And if it's too tight, there are future risks of patients' harm. So you have to strike a balance between patients' safety and residents' training. So these days, there are a lot of discussion about whether surgical training is of good quality or not. So I did a recent survey with my postgraduate training, and I found that not all of them were satisfied with their training, and they think that they would not be able to do independent practice after that. And it's not with me only. It's with the US graduates as well. About 1/4 of US graduates don't feel confident enough for independent practice. And surprisingly, this is a fellowship program survey in US that they found that 30% could not perform independent lab colleagues. So there's a huge issue. And why is this happening? Because over a period of time, the surgical training has changed because there are a large number of surgical residents, there are less training slots. So they're not getting the proper case volume, and that's why they have to seek additional fellowship trainings. So what are the current challenges in our setup? So what I found is there are problems with the input, problem with process, and the problem with outcome. So input, there is no interview, so the selection is based on numbers, and there is no qualitative assessment. The second is the process problem. I think the biggest is the standardization of training. So not only the trainees are not up to the mark, less skillful, more knowledgeable, but they have lack of professionalism and political activism, and lastly the female numbers. So because of that, there's a huge issues of training. And not only that, trainers are also not well equipped with the modern surgical techniques, especially the advanced laparoscopic skills and robotic skills. And that's why the people are not getting uniform laparoscopic exposure as well as robotic exposure. And lastly, about the training curriculum, there is a lack of standardized training. There's more emphasis on apprenticeship and time-based rather than competence-based training. And that's the reason the outcome is of poor quality. So what are the different solutions? I think the best is to have a better selection process, whatever MD care or whatever process, they have to involve the interview and they have to involve the trainers. Secondly, I think the solution is adopting modern competency-based training models and then enhancing the skills of both the trainees and the trainers by using the simulation. And I think not only they need training in simulation, but they also need training in leadership and teamwork. And lastly, accountability of both the trainees and trainers should be there. And this is the pyramid, which will facilitate trainee autonomy, to starting with a competency-based curriculum, to simulation, to self-directed learning, because they are self-directed lifelong learners. Now, we know that simulation can bridge the gap and it shortens the learning curve, improve the operative efficiency, and more importantly, it improves the patient's safety. Now, despite the fact there are still challenges to overcome, and the first one is a political will. Then who is going to bring this huge volume of change? Because you need to design and update curriculum. For that, you need the capacity building of the faculty. And unfortunately, the regulatory bodies are also not working. So my summary is that the quality of surgical PG surgical training has hampered over a period of time, but it can be improved by better selection process of the surgical trainees, designing and adopting the EPAs or a competency-based structural training program in which the focus is on mastery. We also need to train the trainers, and I think not only the pedagogical skill, but I think simulations can be used to train the trainers in advanced laparoscopic and robotic surgical training. I think the key is simulation. We need to build up more simulation centers so as to improve the patient safety, but at the same time, increasing the trainees' proficiency. And lastly, we need better assessment at workplace as well as summit. I thank you very much for your patience listening.
Thank you very much, Dr. Afzal.
Thank you very much. May I just say hello to everyone?
Hello.
Hello.
Yeah. Is there any questions? I'm ready to answer those questions at the end.
Will be at the end.
We'll be taking them at the end. Yeah.
Thank you.
I'm delighted to introduce the last speaker, Professor Maudud Alamgir, past president of the Society of Surgeons, Bangladesh, 2014 to 2017. He has visited many times to Sri Lanka and a recipient of honorary fellowship of our college. He is the professor and head of Department of Surgery, TMSS Medical College, Bogura, Bangladesh. His special interests include medical education, training, ethical and moral issues in the profession. Over to you, Maudud.
Good morning and warm welcome to Sri Lanka Surgical Congress 2020. Mr. Chairman and the delegates, it's a different situation. We are missing the flavor of the Sri Lankan tea and the classical Sri Lankan spices, but we're talking on the emerging trends in surgical training, perspective, Bangladesh. I am Professor Maudud Alamgir, the past president of the Society of Surgeons of Bangladesh. Bangladesh is a country which has the largest mangrove forest and the majestic Royal Bengal tiger, and also we have got the longest uninterrupted sea reach in the world. And another largest is the National Institute of Burn and Plastic Surgery, is the largest of this nature in the world, which caters about the education, training, research and services. Bangladesh is a small country having a population of 180 million. And we have 90,000 graduate doctors, and one doctor has to look after 1,800 people.
The basic health structure is available even in the remotest part of our country. But the number of general and allied surgeons is a big question. We have only 4,500 and one surgeon has to take care of the 38,000 people. The challenges is tremendous. The trainer-trainee ratio is a big question. Availability of the training slots is a big question. Training facilities are limited. And global challenges of acquiring the newer technologies is also a big issue. Our training rotates around the Bangabandhu Sheikh Mujib Medical University with the affiliating organization. We have got the Cancer Institute, the Children's Institute, Gastro-Liver Institute, the Neuroscience Institute, the Institute of Traumatology and Orthopedic Rehabilitation, and the Cardiovascular Institution are the notable ones. But today we are talking about the National Institute of Burn and Plastic Surgery. This caters on the acute burn, post-burn reconstruction, trauma reconstruction, congenital anomalies, cancer reconstruction, hand surgery, breast surgery, oncoplastic surgery, cleft and craniofacial surgery, aesthetic surgeries, and so on. In 1990, we had only 5 plastic surgeons, but now we have 108, but the number is still. In 2003, the MS course was introduced. And in 2019, this 500-bedded National Institute of Burn and Plastic Surgery was commissioned. And this is the picture of that. It caters on the classical class schedule with journal clubs, recent advances and others. Has the educational resources of standard academic activity connected locally and globally. The training facilities rotates around. There's basic plastic surgical skill lab, basic trauma life support course skill lab, wound care center, microsurgery skill lab, cadaver lab, skin bank, IT labs, and so on. There's the training picture. And the training collaboration is with the other global similar type of organizations you can see from here. And the research activities also a part of this charter. They are publishing 2 journals from this institution and the association. And services, you know, they have the Eastern Bloc dedicated for the burn care and the Western Bloc for the plastic surgery cares. And the specialty clinic is the aesthetic surgical clinic, breast surgery clinic, cleft and craniofacial clinic, cancer reconstruction clinic, burn contracture and the keloid clinic, vascular malformation and the lymphedema clinic, and hand surgery clinic. And these are the proposed area: breast, oncoplastic, and hands. And this is the picture of the facilities and ICU, the operating theatre, the skin bank, and these are the range of the facilities they are providing. And this institution can also take care of the training facilities to be imparted to the Bhutan, Nepal, and the 7 sisters of India, and also to the Sri Lanka. And with this, I just invite you to join the forthcoming national conference in December, and also invite you to visit the exotic historical sites of the Paharpur, Mahasangar, the famous historicals for the Buddhist. And with this, I just want to say you all thank you for giving me the patient hearing. Thank you very much.
Thank you, Maudud. I think we have very little time for questions, so that I will invite Professor Alvehare to make the concluding remarks.
It's a privilege to be here. SAARC region. My one fear, my one comment is that we remember that there are a very large number of poor and disadvantaged people who've got families, who've got dietary and other problems, and that we make sure that the sophistication we have does not detract time or care or attention or cost from the most basic surgical needs to the most basic people in the population. But I'm sure that we'll be well looked after given the competence that we have seen displayed during this session. Thank you.
I think that's why you coined the word, the name Surgical Care Society.
Yes, Surgical Care Society.
All right. Thank you very much, you all.
Thank you.
Thank you, everyone. Thank you.